all of the lines
The conference has been muted.
of today's webinar, just so that we don't have background noise on the recording. And if you have any questions and would like to have me answer them during the course of the recording, please send them to me via the chat feature, and I will answer them as soon as I can. Today's webinar, and thank you for joining us, today's webinar is to really talk about what's going on. What are the changes that are underway in healthcare, community health needs assessment, and community benefit, and what are the implications? And I use the title for this, Institutionalizing Your Community Health Needs Assessment. And the reason why I use that as a title, because a lot of people still, even after this needs assessment process has been required by the IRS, there's a lot of people that are looking at this process as a point-in-time activity. Every 3 years I got to do a community health needs assessment. And it's this compliance activity over here that we're stuck doing because we have to do it. And what I'm really hoping that people will begin to understand, and I'm talking a lot about it with anyone who will listen, quite frankly, is that this is an opportunity to really look at making the shift to population health and really looking at how you can, as a health system, achieve your marketing, revenue generation, and population health improvement outcomes and impact through your implementation strategy. And you should be thinking about this holistically, not just about meeting the IRS requirements, but how are we really making the shift to accountable care that's being talked about as part of the industry change in healthcare. And the other thing that I hope to do will help you connect the dots a little bit and see that you can really, through your community benefit efforts and through your implementation strategies, you can really impact the community. There are ways to do that. And it's just not about did you impact the obesity rate in your county. It's did the program that you implemented, was that successful and achieving the outcomes and impact it was supposed to achieve. So we're going to talk about those things. For those of you who are not familiar with Strategy Solutions, we're a kind of a boutique consulting firm with a mission to create healthy communities. And I started the company 15 years ago out of my work as what I then called the CEO's Rent-A-Planner. I worked for a hospital system in Northwest Pennsylvania. I was the spiritual leader of the community health movement, and every community agency or organization that needed help got me and my staff. And I actually left the hospital business because I recognized that the hospitals weren't going to solve the community health equation. That healthy communities were actually created by the intersection of private sector wealth-creating companies that were in communities that had strong community and government, which includes the municipal infrastructure, economic and workforce development, including education, and then a strong social service sector, which included the community and faith-based organizations, as well as the hospitals. So I left because I felt that somebody had to figure out how the system sectors work together to create a healthy community, and spent the better part of the last 15 years learning how to do that. And our process, regardless of what we do with the clients, we're always looking at having people call the question on where are we now, where do we want to be, how will we get there, who's going to do what, how are we doing, and really ask those 5 questions. And our community health needs assessment process should be doing that as well. And when I raise the term, or I talk about the term institutionalizing, what I mean by that, especially related to the China here, or this community health needs assessment, is have we made a shift from this item, the community health needs assessment, being part of the way we do business and not just a point-in-time activity that we do every 3 years. When we've institutionalized something, we've made it part of our way of working. We've made it part of our organization or part of our process in a community. Like one of our participants today is Colleen Heim from Blair County, the Blair County Coalition, which is an 86-member coalition in Blair County. They are institutionalizing their community health needs assessment process through the collaborative, which a lot of communities do. But it doesn't leave each individual hospital off the hook for having implementation strategies that are, one, collaborative with the community, but they also have to have their own internal implementation strategies. So our planning process seeks to say, how are we doing with this? And today I'm calling the question on, are your organizations actually beginning to make this part of your way of doing business, not just an activity that you do every 3 years? And before we jump into it, I want to just give you a little bit of a background on what our approach is. Because Strategy Solutions, what we're best known for is helping organizations build the bridge from strategy to execution. And whenever we work with one of our clients, what we're doing is, even if I'm doing simply a training program, I'm helping people as part of that process assess the gap between where they are and where they want to be. In some cases, we'll fill the gaps immediately through best practice role modeling, and then we make sure everybody's all on the same page, and then move forward. And what do I mean by that? We're assessing the gap. We're comparing vision to reality. We're looking at your current capacity versus best practices and looking at process gaps and skill gaps, especially if an organization is stuck. Like, for example, I'm talking to lots of organizations in the last 6 months that, we don't have any idea how to evaluate our impact. We have some of these outcomes, but how do we really think about this? And so we're looking at, well, how are you doing this and how are you doing that? So we're asking questions to look at the process and skill gaps. And I'll give you an example. With one organization, they were asking questions about evaluation, but once I really sat down and talked to them, they actually had about 90% of the evaluation process in place. They simply didn't know it. They didn't know how to label it. They had never called what they were doing an evaluation process. And it's like, yeah, one simple thing can help you make it work. And because it was fascinating. And I'm like, oh, this is easy. Yeah, well, sure it is. You had most of it in place. You just didn't know what to call it. And then we help them to develop a plan. So if there is a gap, the process gaps and filling the skill gaps are part of the action plan, not just the stuff they want to do, but building their capacity becomes part of it. The other thing that we'll do when we're working with an organization is we'll actually help them assimilate their change management strategy. In some cases, we use this unfreeze, change, refreeze is a well-known change management strategy. In some cases, we'll be the accountability helper. Like today, I'm working on a succession plan for a pretty sizable national nonprofit, and these are all smart people and they have good systems, but they're all busy. So having somebody actually help them think through what they're doing and what needs to go into their succession plans is really helpful. We also have some content expertise around that, so that helps too. We can sometimes teach and coach new skills. Like, we've taught people how to do data analysis, data synthesis. We've taught people how to actually develop reports. In some cases, we'll do at first a teach and coach. Utilize outside expertise if necessary, and challenge staff to go the extra mile to fill capacity gaps, because oftentimes things don't happen because people say, well, we don't have staff to do this. Well, okay, you don't have to hire somebody with a PhD in evaluation to be able to get this work done. You don't even need somebody with a master's degree in public health. You just need a process to know how to think about this and put the systems in place to get it done. So we'll challenge the staff to do what they can do without hiring anybody new and make it the way of being. And then we'll align the organization from top to bottom. Sometimes it's getting the board and management on the same page. Sometimes it's getting the management team on the same page. Sometimes it's the management and staff. And sometimes it's the system and donors. And what do I mean by that is, being able to make a case for support for funding something new or building organizational capacity if you don't have the wherewithal to do that or to do something new on your own. So with that as a background, Which of the following best describes you? Go ahead and pick on your screen. Are you a manager or director level staff? Are you an executive director or CEO? Are you a staff member of the organization that you work with? Or are you something else? Go ahead and vote, and then we'll look at the responses once we have them. And I have a couple of evaluation slides further on in this presentation. Anybody else want to vote? Okay. Here's our group. Half of the group is manager or director level staff. Okay, here's what we're going to be talking about. As many of you who have seen my webinars before will have seen this IRS Guidelines staff. The letter of the law is community health needs assessment needs to be done every 3 years, chronic disease, blah, blah. But the spirit of the law is that we're going to be managing the health of a population to achieve the triple aim. This is really the spirit of the law. And if we're going to be looking at moving toward population-based health planning, we have to ask ourselves these questions. How effective are our community benefit and implementation strategies today? And when I say effective, how effective are they at impacting the health of the people that we're serving? And then, how do we raise the bar and institutionalize the process? And again, when I say institutionalize, I mean and make it a way of being and how we think organizationally, not just how the wellness department works or how the community benefit department works, but are we moving our thinking toward population-based health planning? So I'm going to ask you this question, and the bullets that are on this slide are actually the answers that are on the next slide. Okay? So which of the following best describes your hospital and health systems approach? Is your hospital actively shifting toward the second curve? Are you involved in a CMS demonstration project? Are you involved in or managing an accountable care organization? Many folks are now involved in an ACO somewhere, even if they're not running it. Are you participating in an at-risk contract? I've talked to many hospital CEOs and CFOs that they're selectively tipping their toe in the water on some risk-based contracts with the payers. Are you measuring the health status, the outcomes and impacts of your clinical and or outreach programs? Or are you struggling with measuring outcomes and impact? Are you narrowly defining implementation strategies only as community benefit? Or and I know some people were here, ignoring all of this completely and hoping it goes away. I know a few of those folks. Or ignoring this completely, hoping to catch up when the reimbursement system changes. Because I've actually had CEOs tell me, I'm not going to worry about this until after I have to worry about it, okay? So I think this is set up so that you can, this poll here, okay, you can click more than one. So if your organization is involved in an ACO, you can click that. You can click if you're participating in at-risk contracts. Or you can click on, and if we're doing some of that, plus we're ignoring the evaluation, so you can click up to 2 or 3 of those. As a matter of fact, as many of them as you like. I think you should be able to click on multiple things. I'm curious as to what is going on in your organization. Go ahead and vote. I love I can see the results as you're voting on these. I love this, okay? Because here's what we got, okay? The good news is you're the enlightened folks that are on the phone, okay? You're not ignoring it. Your organizations aren't ignoring it, which is really great, okay? And and this is actually what I suspected to see. We're measuring the outcomes and impact, but for the most part, our implementation is our community benefit. Some of us are involved in those risk-based contracts or CMS demonstration project, but those are activities that are going on someplace else in the system. We're not really connecting the dots. Here's another question for you. How effective do you feel that your hospital or hospitals, if you're part of a system, and I know some of you are part of the system, how effective has your organization been in implementing your community benefit and community health needs assessment related interventions? Go ahead and vote. This is not uncommon, okay? The good news is that no one is feeling not effective, okay, which is great. And for those of you who are feeling very effective, I suspect I know who you are, and I would say many of you are doing pretty well. But I think there's more to do. And that's why we're here today, okay? So what should we do? What are the kinds of things that we should be thinking of to get our organization to the next level? The first thing we should do is think about how do we position the needs assessment process to drive and evaluate whether your hospital is successfully transitioning to population health, okay? The CHNA process should be the driver and the evaluator of your population-based management strategy as well as your overall strategic plan, quite frankly, okay? Well, and how do we do that? These are the 5 things that we're going to talk about over the next half hour. Embrace the vision to engineer the new healthcare delivery system. And what does that mean? In some cases, you're already doing it, but we don't have the dots connected in many of our health systems. So this is probably a good place for me to chime in and say, if you feel that your organization, and that's we don't have any CEOs on the call today, but if you feel that your C-suite would benefit from this education program, yes, I'm sending you the newsletter and the slides, but I'd also be happy to do this presentation for your organization for free, either via webinar, if you'd like me to do it via webinar like this, or if you would pay my expenses, I would come and do the presentation for free to the audience of your choice. Just because I'm such a cheerleader about getting this word out, I'd be happy to do that. So get the vision. The second thing is actively tie your needs assessment to your planning and budgeting process. Some of that should happen this next round because you have to put a strategic investment budget on your implementation strategies, but that doesn't mean it's necessarily connected to the strategic thinking in your organization, and it should be. We also suggest that you adopt innovative program models that address sizable populations through your implementation strategy, and if you're already doing these innovative programs in your organization, tie the program back to the needs assessment. Because quite frankly, you wouldn't be doing the CMS demonstration project, for example, if there wasn't a need in your community. So you probably did the needs assessment to fill the grant application, but it's somewhere else with your, it's somewhere else in your health system. It's not connected to your CHNA process. And then facilitate new and creative programs and structures that encourage shared risk and reward between and among providers and payers, and that includes the continuum of care in the community, and then build internal capacity to facilitate the CHNAs, implement evidence-based approaches that connect clinical intervention and automate the outcomes measurement and evaluate the outcomes of the programs. So there's ways to do that. So we're going to talk about each one separately. Here's the first thing. Embrace the Affordable Care Act vision and recognize this. Community health improvement strategies don't have to be community benefit, but all community benefit strategies should tie to community needs in some way. So this one usually takes people a couple of seconds to wrap their heads around, okay? Because your strategies don't have to be community benefit. In other words, yes, you can make money on a community health intervention if you're targeting a population that has insurance, which is fine. Nowhere does it say that you have to do all this stuff for free and that it can only be free stuff. It doesn't say that anywhere. And you should be cross-connecting the community benefits that you're doing back to your needs assessment so that you have validity to the work that you're doing from a community benefit perspective. I actually developed this slide because I used this triangle, like the pyramid of Maslow's hierarchy of needs, because I see an evolution happening with community health the community health needs assessment and interventions. Like when people get first started with this, and many hospitals got dragged into doing needs assessment because it was compliance only. Some CEOs I know got dragged in kicking and screaming, and they're still at that I'm only doing this because I have to mode. And so that's the bottom rung. I'm doing it because I have to. Above that is we have some folks that are doing things because they're prevention focused, or some people are doing only like health fairs and screenings and some prevention focused things. They're not out working in the community or working with community partners, and that's fine. So that's kind of the next rung on the ladder. Some folks are doing programmatic interventions to improve health status, to really help improve the health of a population. They might be doing it as a byproduct of a readmission strategy or something, but they're doing things to really improve health status. These other ones, what I found is that when people get really involved over time doing community health needs assessment activities, you really can't help but butt up on the social determinants of health. I mentioned in the beginning, this is why I left the hospital business and started Strategy Solutions, because there's so many other factors that contribute to a healthy community. It's not just the health status of an individual. And we need to be thinking now about the population health. And if you really think about the health of a population, you're going to start thinking, you can't help but hit up on those social determinants. So the higher order things on here really start to look at collaborative interventions to impact the health status of a broader community or a region, a neighborhood, a city. That starts to look at social determinants. Or collaborating across sectors to address root causes. Like part of the reason why I have a readmissions problem is because I've got people that don't have food, or I have some in my population don't have adequate housing. And then at the very top of the pyramid is influencing public policy to create healthy communities, like really getting involved in your municipal transportation plan in your region so that you can create walkable communities and sidewalks and bike paths and things like that help to really create health, or look at economic development and jobs. So some of these questions, and I don't have a poll, but you should be asking yourself and asking your senior leaders in your organization, where are we? Where are we along that continuum? We also should be looking at what's happening across the country on these community benefit topics. And part of the packet of information that I will be sending to you, you'll get as I mentioned earlier, you'll get the presentation, you'll get a copy of my newsletter article. I also will send you a copy of the Hilltop Institute issue brief from June 2015, which is, it's a great white paper on what's happening with community benefit across the country and how states are trying to help move the Accountable Care Act along. Some states are getting involved and doing things more proactively than others. Because they are really looking at new payment models. Global budgets are starting to address the triple aim in some contracting. Population health is realigning the hospital business model. We see that more and more. The triple aim is the framework for healthcare reform. So some of these things are happening, and this issue brief does a nice job of explaining what some of the states are doing to help move this along. And the Hilltop Institute is actually encouraging state policymakers to help move it along faster by doing things like building on the federal rules to encourage community building, electronic reporting, and greater stakeholder involvement in those community health needs assessments. And I'm actually hoping that the feds get wise and they put some dollars into the healthcare information infrastructure investments that some hospitals are going to have to make, sort of like they did for meaningful use, and make it financial incentive to create some automation of these outcomes indicators. I'm actually doing a pre-conference workshop for the Association for Community Health Improvement Conference next March in Baltimore, so I'm doing a commercial for them also, on how to think about automating indicators and how to really collect data and automate it in a way that you're not keeping track of this stuff manually because it's just too hard. So that folks actually do invest in data collection and performance metrics, and encourage payment reform that rewards value, promotes population health, and promotes regional collaboration. And I say this to you because, especially for those of you in Pennsylvania, Pennsylvania is backward compared to a lot of states, and I apologize to our state policymakers by saying that, but it's true. Many states are way further ahead in some of this thinking. And as people like the Hilltop Institute encourage state policy to move in this direction, even Pennsylvania is going to eventually move in this direction whether they want to or not. So this stuff is coming. The question is, how prepared do you want to be for it? And I love this slide. Again, those of you who have seen my previous presentations have seen the left hand to the blue and the pink of these slides. This green box, the green boxes here, this second curve of population health is brand new. I saw it for the first time at the end of June in the AHA Smart Market Road to Accountable Care webinar. And if you look at that second curve of population health, we're going to see value-based reimbursement, seamless care across all settings, proactive and systematic patient education, workplace competencies and education on population health, integrated comprehensive healthcare information technology that supports risk stratification and real-time accountability, and mature community partnerships that collaborate. Okay? This is where we're going. So how do we begin to connect the dots? Well, here's how we got to start looking at it. Right now, we have our community health needs assessment stuff and our community benefit prevention, those two ovals that are in the center there. Most of you said at the beginning of this webinar that's where we're at. Then we have these readmission post-acute continuum of care strategies out to the left. And on the right, the service line development is the things that we do internally, and those are kind of out there, all on their own, okay? And what I'm suggesting is we start to think about it all together. Embracing the Affordable Care Act vision means that we put the input and the data should be driving decision-making and intervention, and our strategies all become part of the same, looking at healthcare delivery. We're looking at them all together. And I love this slide because this slide actually shows the whole continuum of care. And if we look at the bottom part of this, the green little box there says healthy, and then the blue says at risk, and then chronic and complex. Our community benefit strategies usually are geared toward healthy people or at-risk people. Things like workplace wellness, prevention, health promotion, screening. Those are most of our community benefit activities. And in some cases, those community benefits are our CHNA implementation activities. because we got to get people access, because access is a big issue. So a lot of those become the intervention strategies. But as you get more sophisticated in your thinking about this, the implementation strategies are often targeted toward at-risk or chronic disease patients, our diabetics, our people who are obese. You know, we got to do something about that, and we got to do something meaningful so that we can, in some cases, save people's lives. And then the chronic and complex are the acute care, the service line programs. And what I'm suggesting is the green oval, which is we got to look at them across the continuum. We have to watch and monitor and follow people as they get involved with a screening. We got to follow them through our system and have a mechanism for measuring what happens to them downstream in our process, which is going to require us to rethink how our information systems to support what we do. And these next slides, I left them in here. When I do a workshop for a individual organization, I'm going to poll these questions using the option finder audience response polling system. But I left them in here because I want you folks, when you get the slides from today's session, I want you to be able to look at them and start asking these questions internally. You know, how important, do people think it's important in our health system to measure the impact across the continuum of care? Do we think it's important to implement system-wide community health implementation strategies? Like, for example, I was working with one hospital system that each hospital, of course, should have their own implementation strategies. I know some systems that have, 3 goals, and all the hospitals are doing their individual part working on those 3 goals. But in some cases, every hospital is doing their own thing, and they're not looking at, well, what's the system doing together? You need to ask, how effective has the hospital been in its ability to impact? How important is it for us to measure the collective impact of a system-wide effort? So if you have, 13 of 15 hospitals in your system actually doing the same kind of work, what's the collective impact of that? We should be thinking about that. And the last question is, how important is it for us to promote those kinds of outcomes and marketing as part of what we're known for? Is that what we're doing? Is that part of what we're doing, and how important is it? Those are questions that we have to ask. Okay? So we have to be thinking about it across the continuum of care. And we have to engineer what we're thinking about in terms of doing it that way. So here's some other information for you to ponder, okay? Does your system even have a complete continuum of education, prevention, care management, acute and post-acute care, okay? Do we have that all? And these are questions that the highest level in your organization should be asking, okay? Are we moving from episodic management to care management? This slide actually comes from the advisory board company and talks about how we move from traditional fee-for-service to population management. We're redefining value-based payments. We look at condition management and then move to population management. But what I've discovered is that if organizations are doing this, it's like the finance and clinical people are doing one thing and the community benefit people are doing something else, but we're really not working on it together. And my hope is that people start to think about it together because it's all part of the same process. And here's the way to think about it, okay? And this is a little graph of the planning process. It's because we have to not only engineer the parts of the continuum of care, we also have to look at how does the needs assessment become our driver and our evaluator, okay? So here's how. We ask the questions, where are we now, where do we want to be, how are we going to get there? And in the beginning, when we start a planning process, usually leaders sit around and say, okay, what do we need clinically? What kind of doctors do we need? What kind of new equipment do we need? What kind of new programs do we need? But what we also should be looking at is what does the needs assessment say, and what are the priority needs and issues in the community? Because guess what? It's actually the same programmatic needs that the internal conversation is going to come up with as part of the internal conversation. So, if the docs are sitting there saying, we need a surgeon, we need a general surgeon because we have cancer cases, or we need a surgeon that can do breasts because we don't want them to leave our community, okay? That actually relates to the outreach activities and screening for mammography. That's all part of the same clinical process, okay? So we should be talking about those things together at the start of our planning process. We should set goals and objectives for the hospital that reflects those so that you have your implementation strategies as part of your operations plan, which, oh, by the way, is part of the IRS Guidelines. And then we should have the clinical and operational strategies that we typically have in our strategic plan, plus we should have our China implementation strategies. They should be all together, and we should do them at the same time. And then we should have defined action plans that are both internal and collaborative and are tied to our budget. So that if we're working with the Blair County Collaborative on an obesity program, that we actually have that obesity program, that our component of it from UPMC Altoona, we've got that, that hospital's component is built into their budget, and it becomes part of the action plan so that they're working on it together. And if we've got, we're doing breast cancer screenings because we've got a breast cancer problem, and we have a 3D mammography unit, or a 4D now, we should be marketing that by trying to get as many women and men who might be at risk for breast cancer, get those screenings done. And then at the end of the year, we should be saying, are we getting a return on investment? Are we lowering costs? Are we improving health status? Are programs making a difference? We should be evaluating that on the back end of it and asking ourselves the question, do we make a difference? And then update our strategic plan to reflect that. So in other words, the action plans that we do on the back end of our community health needs assessment shouldn't be a separate action plan that sits out there somewhere. It should be a component part of our internal strategic plan and be part of our internal process as we talk about it together, okay? So I'm going to stop and ask this question. How well integrated are your community health needs assessment processes with your hospital and health system planning processes today? You can click don't know if you really don't know. You can click not at all if they're completely separate. You can click somewhat if they're somewhat tied to each other, because I've seen lots of organizations that are doing some stuff together, but some that are like just out there on their own. And I know a couple that have them pretty well integrated, but those are really few and far between. I love this. No one here, somewhat. And that's what I see most people are somewhat, okay? But we should be moving them, okay? And that's how to think about it. The third thing is to adopt integrative program models that address sizable populations through your implementation strategy. So how do you do that? First of all, you look at large captive audiences. And can you do, or are you already doing something with that large captive audience? You should also be looking at innovative care delivery programs that you may be already doing. And you should be asking yourself the questions, or looking at how efforts connect across the continuum of care and or across community agencies. And some of the examples I talk about, and I talk about a lot, employee wellness, okay? Your hospital or hospitals are probably the largest, if not one of the largest employers in your communities. You may or may not have an employee wellness program, but if you do, there's a community health implementation strategy. And you can impact, I know of companies, I know of hospitals that have employee wellness with a strategy that they want to get the top 10 employers in their region doing the same kind of program they are. They're going to get 70 to 80% of the population in a wellness program if they get the top 10 employers to buy into what they're doing. I mean, that's huge. That's huge. That's you take away the effort of, like 14 million screening programs that you can't get people to come to. Then you have to think about the safety net. But again, critical mass. Or you can look at transportation programs. I know many organizations that are doing transportation to try to get people to the hospital for care. But there are community transportation programs that exist that get people to the hospital, but we're not looking at the hospital outcomes and what might the outcomes not be if those people don't have transportation. Things like community paramedicine. If you're not familiar with community paramedicine, that's a project where paramedics actually go to people's homes to help them do chronic disease management. Those kinds of projects make a huge difference in improving the health of the population, or the readmission strategies. Every hospital has some effort toward readmission strategies, and usually for people that have things like COPD, congestive heart failure, diabetes. Oh, by the way, those are the top 3 priorities on our community health needs assessment. Why aren't we looking at what our readmission strategy intervention is doing and how it's impacting the health of those people? Maybe we should. So I encourage you to think about those captive audiences and how, because you can get a lot of leverage because those kinds of programs are touching a lot of people. And then we have facilitate new and creative programs and structures that encourage shared risk and reward. So how do you do that? Well, I put some slides in here from the Healthcare Advisory Board again, because these attributes of the High Performance Healthcare Network, the Advisory Board published this, I don't think it was last year, I think it was actually the year before. This was probably published in 2013. And I like these slides because these slides talk about a lot of different creative programs that are scalable, team-based, patient-centered, comprehensive, collaborative, interconnected, and inclusive. And as we move toward population health management, each of our hospitals and health systems should be thinking about how do we build the elements of these kinds of programs into the way we do business. Not a separate program or an implementation strategy, but how do we shift the way we do business to move towards population management? And these are some of the ways to do it. We look at scaling, okay? And managing 3 types of revenue streams. So, and I mentioned earlier that one of the features of the second curve of population health is stratifying patients based on risk. If we're looking, and we've got to do different kinds of interventions for high-risk patients versus medium-risk patients versus low-risk patients. And, if the goal is to keep those patients healthy and loyal to the system, we're going to be doing, prevention, screening, those kind of things. We're going to be avoiding unnecessary higher acuity or high-cost spending with the interventions with those medium-risk patients, and we're going to be working on those high-risk patients, trying to keep them out of the hospital and trying to do the best we can for them, okay? One of the things that the advisory board recommends is revisiting the medical home concept. And, medical homes, I know many hospitals, even in Pennsylvania, have implemented medical home concepts or attempting to implement medical home concepts. And some people have been struggling with it, others have done it well. And some of it depends on, whether or not you get reimbursed for case management. But your systems ought to be looking at programs like this because, we're not only are we talking about medical home, some people are talking about diabetes medical home, and some are looking at a behavioral health medical home. Maybe we should just look at taking care of the people that we serve in some holistic way. But again, it's a program model that can work, okay? We also ought to be looking at, our services patient-centered, okay? And are we care coordinating appropriately with the various inputs in the care management? Again, you can set up something innovative that uses your physician's offices to manage care differently, or in some cases, when people show up at the physician's office, Those are actually outcomes and impacts of your prevention and screening programs. You need to be looking at that across the continuum of care. In some cases, and for those of you who are higher up that hierarchy and you're recognizing that the underlying problems of the social determinants of health they impact your patients. And our programs ought to be comprehensive, looking at those social and economic determinants of health, such as housing and behavioral health and food and transportation. And looking at, can we standardize our approach and can we address the barriers to care? Because that's really what population management is about. And are we integrating across the continuum of care and looking at, are we connecting worksite clinics, doctor's offices, home health, pharmacy, community agencies, behavioral health? Are they all part of our network that we could start to think about what happens to our patients over time? And then are we creating a new are we interconnected? Do we have an information systems infrastructure that allows us to share information? And then are we engaging patients and family in the care and really working on how our electronic medical records share information with caregivers and with families and with patients themselves? There's some good examples. So this information is for you to really think about and ask questions in your organization. Are we doing something about this? And then are you looking at integrating physical and behavioral health? This slide was published by the advisory board back in 2013 about the 7 things that are likely to happen with behavioral health over the next few years, and sort of switching the model to deploying telepsychiatry and integrating physical and behavioral health and looking at community partners. So, these are questions that you have to ask yourself, because any of these strategies help you move down that path toward population health. And if you're doing all of these things together, you ought to be thinking about taking credit for it as part of your community health implementation strategy, because you're probably measuring the outcomes of it anyway. You just don't realize it. Or you're not connecting the dots in your leadership team to say, these are our population health intervention strategies. Why don't I look at it that way? And here's the community benefit stuff that I'm doing in terms of outreach and prevention and screening that helps me eliminate barriers for underserved populations and actually get them into my system. That's what we ought to be thinking about. And then lastly, we should be building internal capacity to facilitate these things, implement the evidence-based approaches, and connect with clinical intervention efforts, and then automate the outcomes. And when I talk about building internal capacity, I'm not talking about every hospital ought to build the capacity, because the internal capacity ought to be built in the community. And whether you're working collaboratively with other players or not, you ought to be thinking about which players can provide which support. And you can get pieces and parts of these components from 6 or 7 different agencies or a university. Again, this isn't suggesting that you hire 35 people in the hospital. That's not what I'm suggesting here. I'm suggesting here that there are competencies that need to exist in a process and an ongoing process that pulls this all together, that you ought to be looking at. How does this happen all the time? And how do we make it part of how we do business and not make it just part of Susie's job or Nancy's job or John's job? It's how do we do business? So there's 2 components of it, okay? The one component is to facilitate the needs assessment, and there's activities under it like primary, secondary research and stuff like that. And then it's the branding our system as the care delivery innovators. We're doing something different to impact the health of our population, and we can prove it, okay? And that's looking at implementation strategies, facilitating new model program development, and then evaluating impact. And I'm going to talk about each of these separately, okay? If we're going to facilitate our China, what do we need? We need process facilitators. We need data collectors. We need program developers. We need information management support. We need evaluators, and we need communicators to help publish the results. Okay? So those skills don't have to come from one person or from one agency. They just need to be somewhere, and they need to work together to produce an outcome. We also need to facilitate new model program development. So what does that require? Well, we got to research evidence-based models. We got to look at and envision a program. We got to have some cost accounting, reimbursement, and cost-benefit analysis somewhere. We got to have utilization review and actuarial analysis, or informatics analysis in some cases. You know, how much is this stuff costing us to do this? The ability to utilize shared staff and connect to community resources in innovative ways. Like, for example, one of our former clients that we helped move through the community health needs assessment process 3 years ago, we did capacity building training with them as we did it, and they're having a local university help them with the data collection. This is good. You shouldn't have to hire an outside consultant. As much as it's nice to be mercenary, you shouldn't have to hire an outside consultant to collect your data. You could be building the systems for it in your local community, and we can help you build those systems. And then you have to evaluate impact, which is the ability to develop tracking and reporting systems manually first and then with IT support. You got to think about internal evaluation for continuous improvement. You got to connect it to your 990, and then you need a marketing and writing team to help you publish the results. And if you want to work on institutionalizing these things, you know, these are the components that you need to think about in terms of institutionalizing it. We need leadership education and support, okay? The powers that be, the leaders in our organization, need to understand how this all fits together, okay? We need to design the organization structure, which means, oh, I have a good project manager in my hospital. I can get some data support and some focus group support from a university, and I can do these other things, okay? You line the players together, figure out who can do what. Establish new processes, okay? Figure out who's going to do what and get it done, and possibly do some technical capacity building. Educate staff on the technical components of it, and work on filling in the gaps and helping people to really embrace it. Because I've had some hospital leaders say to me, oh my goodness, I have one person that's been doing all of our community benefit work or doing all of our community health needs assessment work. If they ever left, we have no ability to continue to replicate this. That's not good, okay? You need to figure out, you know, I remember back in the day, we didn't have quality functions either. I remember working on the first dashboard that my hospital ever did, okay? We didn't have a quality department back then. This is how old I am. It dates me, okay? But we've built that capacity in our systems over the years, and now it's part of how we do business. We have to look at this process the same way. And then we have to determine who owns it, identify gaps, you know, look at the human resources. Can somebody somewhere do it? Can we put it together? And then decide if you'll make or buy it. Will you hire staff? Will you hire consultants? Or you link it to collaborative community resources? But you should be institutionalizing it somehow. And if you're lucky, or if you're smart, you can actually be strategic and be the change that you want to see in the world. And this change is a process, not an event. And my feeling is, and my belief is, and I actually know this, if your hospitals and health systems just start to think about the holistic continuum of care, think about how the process ought to work, start to integrate these 5 strategies, and think about how do I keep this process ongoing. It's not a point-in-time activity. It's how I do business moving forward. Your organization will go a long way to being able to not only measure the outcomes and impacts, you'll be institutionalizing it in a way that is successful and moving toward population-based health planning. So with that, I am going to ask for questions.
The conference has been muted. The conference has been unmuted.
So questions, thoughts? Anyone have any questions? I just threw a lot of information at you, I know. I'm going to stop the recording since no one's jumping in with immediate questions and I don't want to have minutes of silence on here. So thank you.